Good morning and welcome to our instruction course on cataract surgery in patients with ocular comorbidities. Without much ado, let's start the session. The first we are starting with handling uveitic cataract by Dr. Vinita Girish Rao. Dr. Vinita Girish Rao has completed her post-graduation in ophthalmology from Shankara Nethralaya, Chennai in 1998. She had since then been working as a consultant in the Department of Cataract and Uveitis in Sri Ganapati Nethralaya, Maharashtra, and then as a senior consultant in the Department of Uveitis in Shankara Nethralaya, Chennai till date. She is a founder member of the Uveitis Society of India. She has published many papers in peer-reviewed journals and written chapters in books. Over to you, Dr. Vinita.
Good morning to you all. My thanks to KSOS and Dr. Kalemati for inviting me here to speak on handling uveitic cataracts. Uveitic cataracts, as you're aware, is caused by the inflammation, the corticosteroid usage, or often both, and the incidence depends upon the type of the uveitis. Now, one of the most important aspects here is the preoperative control of the inflammation, whether you use oral steroids with or without antimetabolites, even biologics, whatever it takes to control the inflammation. In uncontrolled diabetics or other contraindications, you will need to use periocular or intravitreal steroids. In some cases like Fuchs uveitis or maybe an old toxo scar, you need not give the preoperative steroids. But for most of the other cases, you will need to control the inflammation at least 3 months before the surgery. It's also very important to remember preoperative prophylaxis in infectious uveitis, especially in viral uveitis. We give acyclovir or valacyclovir. We start almost a month before the surgery and will continue at least a month, if not more, after the surgery. In toxo, it is not really mandatory to give the pre-op steroids or pre-op prophylaxis. Let us look at some of the individual uveitic cataracts. Now, Fuchs uveitis is one of the most common cataracts. It is also thankfully the easiest to do because there is no posterior synechiae. Usually presents with a posterior subcapsular cataract and a mild uveitis. The most common complication is the PCO, which is across the board common for all, and glaucoma and hyphema is not so common. Another uveitic entity which can resemble a Fuchs uveitis is a very asymmetric intermediate uveitis, which is a mild, if it is a mild uveitis, especially if it may not have any posterior synechiae and just a mild anterior uveitis, it can resemble a Fuchs uveitis. Now, it is important to differentiate the two because unlike Fuchs uveitis, in intermediate uveitis, you will have to give the preoperative inflammation control. You can differentiate the two by the presence of cystoid macular edema, which is also one of the reasons why there can be a poor visual outcome and one of the common complications. Now, unlike Fuchs and intermediate uveitis, JIA cataracts are challenging. Although the initial reports did say that IOLs were not advocated, but from the mid-90s, successful use of IOLs was reported, mostly because of zero tolerance for preoperative inflammation and better use of immunosuppressive drugs. But in spite of that, there can be challenges. Mostly when you wait for the eye to become quiet, the patients can become amblyopic. And the other challenge is rehabilitating these patients because despite your best efforts and putting the IOL in the bag, there can still be cocooning of the lens or other pre-existing complications like optic atrophy or a band-shaped keratopathy or PC or a ACO. Now, in granulomatous uveitis like VKH and sympathetic ophthalmia, literature studies do say give a good visual outcome, and my experience with that also has been good, provided the patients don't have submacular scar or a subretinal gliosis. For example, in this patient who came to us with a bilateral total cataract, he had been treated elsewhere, but we did not have the reports. Because the eye was quiet, we went ahead with the cataract surgery, and it was only after the cataract surgery that we realized that the patient had a weak age disease. You can see from the sunset glow through the pupil. This man also got back incredibly good vision, although he did develop capsular phimosis later. In HLA-B27 and other seronegative arthritis associated anterior uveitis, we can control the inflammation to a great extent with oral steroids and antimetabolites, but a small subset of these patients may need biologics to control the inflammation. But the most challenging thing is in the ankylosing spondylosis group, you can have a flexion deformity of the spine. You will be able to judge this in the outpatients itself, and this is important because you need to see if the operating table can be tilted to the Trendelenburg position, because many of these patients you need to also stack up pillows under the head. In fact, in one of these patients, the flexion deformity was so much that I had to be almost standing to do the cataract surgery. In very aggressive diseases like Behçet's disease, the postoperative visual outcome is limited by pre-existing complications like optic atrophy or cystoid macular edema. So what are the boxes you need to check before the surgery? Is the eye quiet for at least 3 months before the surgery? What additional pre-op prophylaxis do you need? And what are the problems you may face during the surgery, like posterior synechiae, an advanced cataract, or a pupillary membrane, or a peripheral anterior synechiae? Now, in some cases where the pupil is very small, doing an optos might help you see the fundus. Or do you need to do a UBM, especially where you're suspecting a cyclitic membrane, where you may want to switch the surgery to a lensectomy or a vitrectomy, unlike the default phaco IOL. If the patient has combined cataract and glaucoma and the eye is fairly quiet, you can opt for doing a combined cataract and a glaucoma surgery. Like this patient who you can see she underwent a combined surgery, and the first post-op day is doing quite well. Of course, the most challenging problem intraoperatively is the small pupil. So I prefer to use a Grishaber's iris retractors. I use a 26 gauge needle in the 4 quadrants, and once synoculisis is done, you insert the iris retractors, and after all the 4 retractors are introduced, you can tighten the stoppers to get the adequate dilatation. I prefer a square dilatation of the pupil. What you're doing is creating multiple small sphincterotomies, so you can see micro bleeds there, those bleeds and the pigments on the lens surface. But what you need is adequate dilatation to be able to do a large CCC. Right. So I just wanted to also show that I think it is not working here. That you need to do a surgical PI in all patients where there is iris handling to prevent postoperative glaucoma or pupillary block. Now this is a very old video. I just wanted to show here the extensive synechiae that you can have, very tough sometimes to remove, and as I'm finally able to just separate in one place, you can see the gush of pigments coming out, and then you get an opening from where you can go in and sweep under the iris. Sometimes the entire posterior surface of the iris is stuck to the lens, and many of you may have used Kuglen's hooks to just engage the edge of the sphincter, and then it's gone back again, and just stretch the pupil. So I'll just fast forward here, and once you stretch the pupil, then you can see the pigments over there under the iris, which is just stuck to the lens. So after that, you can just use the viscoelastics. Now, in a situation where you have a white cataract with a pupillary membrane, I prefer to go under the air and remove the synechiae and inject the trypan blue, because the viscoelastics itself may prevent a uniform staining of the anterior capsule. So once you have to look for the pupillary membrane and separate it. Now again it's getting blocked. So you can shear off the, you can so you can just use a shearing force to just take off the bits of the tags of the membrane which is there. That should be enough to give you dilatation. If that is not enough, then you can just make a few nicks on the on the capsular, on the sphincter edge to give you a large good dilatation. The idea is to make a large CCC because ultimately if the posterior synechiae reforms, it will form on the edge of the capsule and not the lens. Now here what some people may prefer a diamond shape or a pentagon shape with a subincisional retractor, and just so that sometimes the tenting of the iris here can be a problem, but usually it is not a problem. You will be able to enter in. My colleague Dr. Sudarshan prefers to use a B-hex ring in cases where there is not much of a posterior synechiae. What kind of IOL will you choose? A hydrophobic acrylic monofocals or a monofocal plus is acceptable if there is no macular pathology, but better to avoid multifocals and definitely single piece IOL in the sulcus. Silicone IOLs are biologically sticky, so you tend to have more posterior synechiae. Hydrophilics are comparable to hydrophobics, but in the long run can have PCO. Just a short view of a large series which shows risk factors in cataract surgery, and intraoperatively they have found zonular weakness, which you also see sometimes when you see the capsular laxity, but does not really lead to drop lens. Post-operatively, we should not forget the primary disease in these patients, the uveitis itself, which needs to be addressed, and posterior capsular opacification, but hypotony can be really challenging. This was a young girl who had come with pseudophakia and chronic uveitis, and went on, as we managed to quieten the eye, the anterior capsular fibrosis increased, but there was a small place from where we could do YAC to open it up. So just to sum up, you can achieve successful visual outcome, especially have zero tolerance for preoperative inflammation if you want to put in the intraocular lens. Of course, there are challenges like pediatric uveitis, chronic inflammation, and hypotony. Thank you once again.
Thank you, Dr. Vinita, for that excellent talk. Next is the keynote address by Dr. Jitendra Singh Bala on intracameral antibiotics, fact or myth. Professor Dr. J.S. Bala is an alumnus of Maulana Azad Medical College, New Delhi, and was HOD Senior Consultant and Academic in charge, DDU Hospital, New Delhi, with a teaching experience of 28 years. He has special interest in cataract and glaucoma, with 53 publications in peer-reviewed national and international journals. He is a chairman, Scientific Committee, ISM, SICS Delhi chapter, President-elect ACOIN Delhi chapter. Awarded Elizabeth Backwell Award by WOS, Dronacharya Award by UC, has received many Best Paper awards and has been reviewer of many journals. Over to you, sir.
Thank you, ma'am, for that kind introduction. At the outset, I'm thankful to KSOS for giving me the opportunity. The topic I'm going to cover is, it's a fact or a fact to start giving intraocular antibiotics. We all know that prevention is better than cure. And incidence of endophthalmitis that used to be 0.087% in the 90s suddenly jumped in the years between 2000 to 2003 to 0.265. And this was because of changes in the surgical technique as we shifted to clear corneal incision, aging population. So there was a need felt for protective antibiotics to combat this rise. What is the mechanism for intraocular bacterial contamination? One is the entry of multiple instruments may carry periocular bacteria, and second is unsutured clear corneal incision. If there is no proper architecture, that may lead to fluid influx into the anterior chamber, and this was proven by a study published in JCRS by Dr. Vasavada et al., where they found that trypan blue stained fluid in the conjunctival fornix was found in the anterior chamber up to 4 hours after surgery when the wound was not properly structured. So this, it has been found that intra-operative contamination of the aqueous humor is known to occur even during routine cataract surgery, allowing the entry of surface ocular flora into the eye. And the transient low intraocular pressures because of poor wound construction in the clear corneal incision may open and the surplus fluid and contaminants may enter inside the eye. And these are the problem factor: non-use of povidone iodine, use of lidocaine jelly, wound leak, increase intraoperative time, and hydrophilic instead of hydrophobic haptics, and simultaneous bilateral cataract surgery, and also anti-VEGF injection given simultaneously increase the risk of endophthalmitis by 2 to 3 folds. These are the various measures that are prevalent. One is topical antibiotics. Some people use 1 to 3 days pre-operatively, and some use 2 hours before the surgery. Subconjunctival antibiotics, almost abundant. 5% povidone iodine preparation is a universal practice, and intracameral antibiotics are very popular in Europe. Povidone iodine, what it does is, it is only for surface decontamination, whereas we have to give antibiotics with favorable pharmacodynamic properties to have ocular protection. And it has been found that povidone iodine, along with the antibiotics, it has a synergistic effect, and it reduces conjunctival flora. Only the povidone iodine, if it is given, it reduces conjunctival flora by 91% for CFU and 51% for species when applied alone to the eye just before the surgery. So perioperative antibiotics have been a common mainstay of post-op endophthalmitis prophylaxis. Now only question that needs to be determined is to suggest the route of antibiotic delivery that might be critical in determining the efficacy. See, if topical antibiotics are not effective in reducing contamination of intraoperative contamination of the anterior chamber. Subconjunctival antibiotics abundant for pharmacokinetic reason. Antibiotic supplementation of the infusion fluid, again it fails to decrease contamination of the anterior chamber. Only intracameral injection of the broad spectrum antibiotic at the end of surgery is able to prevent whatever intraoperative contamination occurs during or after the surgery. And this is pharmacodynamically proven that if topical antibiotics are given several days before surgery or on the day of surgery, the concentration achieved in aqueous humor is close to 2 microgram per ml. With combined regime, again 2.16 microgram per ml. But if you give intracameral injection, you are able to achieve close to 1000 microgram per ml. Why this figure of 1000 microgram per ml is important, I'll emphasize in subsequent slides. And there is evidence by retrospective trials because of difficulty in performing large RCTs, which have proven. This was the most popular study, ESCRS multicentral study done by late Peter Barry in close to 16,000 patients, where they found that in intracameral 1 milligram cefuroxime decreased the risk of endophthalmitis by a factor of 4.92. And these were other studies, Spanish group, Singapore study, Swedish study, all found that the incidence of endophthalmitis decreased from single decimal, like from 0.5% to 0.04%, and similar was the result in other studies which were done across the globe. So according to these trials, there is change in practice pattern in Europe and US. ESCRS 2012 survey found that only 74% of the ophthalmic surgeons were using intracameral antibiotics, but later on, after publication of these studies, the practice increased. ASCRS 2014 online survey indicated increased adoption of intracameral antibiotic prophylaxis. Then 2011 AAO cataract preferred practice pattern guidelines, 2011 ASCRS, 2013 ESCRS guidelines, and 2020 Australia Surgical Antibiotic Advisory Group all have made the use of intracameral antibiotics mandatory. So now which antibiotic, for once we are convinced that intracameral antibiotic is to be given, the next question is which antibiotic for intracameral use should be. These are the various antibiotics available. One is cefuroxime, then moxifloxacin, and vancomycin. The EVS study showed that according to EVS study, 94% of culture positive endophthalmitis cases involved gram-positive bacteria, of which 70% were gram-positive staph epidermidis. And if we see the spectrum of cefuroxime, moxifloxacin, and vancomycin, we'll know the difference and we'll know which antibiotic to be used. But there are some problems with intracameral cefuroxime. One is there is lack of approved intracameral commercial formulation. I'll just take a minute more. And there is kitchen sink pharmacy approach, dilution errors leading to toxic anterior segment syndrome. And there is complete lack of activity against enterococci, pseudomonas, and enterobacteriaceae species like enterococci. Vancomycin is reserved because of its greater efficacy, and it is used for treatment of endophthalmitis. So we should not be using for prevention of endophthalmitis. And there is very severe blinding complication of vancomycin in the form of hemorrhagic occlusive retinal vasculitis, which has been reported in 23 cases till now. So we should use vancomycin with caution. Moxifloxacin is the third antibiotic which has excellent activity against both gram-positive, gram-negative, and anaerobic bacteria. Here I want to really introduce the concept of MIC and mutant preventive concentration. We all know what is minimal inhibitory concentration, which decreases the effect of, which kills about 50% of the bacteria, and 10 times that MIC is mutant preventive concentration, so that the antibiotic dose which is delivered decreases the development of the mutant resistant strains, and so there is no chance of development of resistance. So now I'll come to that figure of 1000 microgram per ml. If you inject 0.1 cc of 0.5% solution, you achieve concentration of 952 microgram per ml aqueous concentration of antibiotic, and the MIC of moxifloxacin resistant endophthalmitis isolate is just 3 microgram per ml. So why we are giving 300 times that dose? Because mutant preventive concentration is 3 into 10, 30 microgram per ml, and we are giving 300 times that dose because we want to maintain this concentration in the aqueous humor anterior chamber for close to 4 hours, and the half-life of moxifloxacin is 4 hours. So this is why we have to give this high dose, that is just 0.1 cc of 0.5% moxifloxacin. So this is Cesar Espiritu from Philippines, who injects 0.1 cc of 0.5% moxifloxacin from the side port after hydration. There are other methods also by Steve Arshinov and Matsura method, as he practices in Japan. So why we use moxifloxacin? No adverse reaction, no TAS, no hemorrhagic occlusive vasculitis, improved spectrum of coverage, and the most important thing is that even if endophthalmitis occur, it will be due to moxi-resistant staph, which is sensitive to standard endophthalmitis treatment of intravitreal vanco plus ceftazidime. Whereas if infection occurs after intracameral cefuroxime, it is due to enterobacter, against we have no treatment. So endophthalmitis reduction, this is the series published by, the famous series published by Dr. Haripriya Arvind in close to 6 lakh cases, and this was in about 20 lakh cases which was published in JCRS. And so although EVS study indicates that endophthalmitis can be treated, but the best treatment is not treatment, it is prophylaxis. So if we know that cataract is the maximum performed surgery in the world, so we want a technique which gives us 100% safety and efficacy. So if we do not want to see red on seeing yellow inside the eye, we should change our practice and start giving intracameral antibiotics in all our cataract surgery patients. I also take this opportunity to appeal to and request all of you for your kind support for my candidature in a coming AIO selections for the post of Joint Secretary. Thank you everyone for kind and patient hearing.
Thank you very much, sir, for the informative talk. We'll take up questions at the end of the session. Next, we go on to the next talk, which is on phacoemulsification in eyes with corneal opacities by Dr. Anita Jabbar. She is a senior cornea, phaco and refractive surgeon working in Little Flower Hospital, Angamali, and Eye Vision Eye Care Center, Chalakudi. She has won many awards to her credit, like Professor Sankara Menon Award, Tony Fernandez Best Video Award, and Professor S. Sivareddy Award, etc. Over to you, madam.
Good morning, and thank you, Kalai, for this introduction and for the opportunity. And I'm sorry for my bad throat. I'm having a severe infection. That's why. Good morning. And let's start by understanding what makes these cases so challenging. So we all know that performing phacoemulsification is a joy when the red reflex is bright and the capsule shines clearly. But imagine the same surgery when the cornea is hazy, the reflex is dull, and every move feels like operating through fog. That is the challenge we face in eyes with corneal opacities, where visualization, precision, and judgment all have to work at their best. So today I would like to share how we can safely perform phacoemulsification in such eyes. I'll be talking about the preoperative planning, small intraoperative modifications, and the realistic expectations you should give to the patient that can turn a potentially risky surgery into a rewarding outcome for both the surgeon and the patient. So here you can see a peripheral corneal opacity, corneal adherent leucoma, where the iris was adherent to the full thickness scar. But here I have performed a toric implantation, and the outcome was rewarding. Thus, corneal opacity obscures the surgical view and increases the difficulty. Here in this video, you can see that there is a peripheral scar, but in between the scar and the limbus, there was a normal limbus, so that you can precisely make your incision over there. The common causes of the corneal opacity being the trauma, infection due to any causes, the dystrophies and degenerations. Also, you have to do a phaco or a cataract surgeries, and also in post-surgical scars. And the goal in all these cases should be aimed for a safe cataract extraction with maximal visual gain. So the preoperative evaluation is also important. Assess the location, density of the scar with your anterior segment OCT, and the depth of the opacity. Like it might be a central opacity, or it might be a paracentral scarring, like what you have seen in the previous video. If it is a paracentral opacity, you can safely perform your surgery. And if it is, there are more challenging cases, challenging situations, then better to, I usually nowadays do it under subtenon anesthesia rather than topical. And if it is a non-dilating pupil, and if the view is hazy and all. And you can assess the health of the endothelium with a specular microscopy, and also a pachymetry to assess the endothelium. So here in this video, there is a post-surgery, post-pterygium peripheral scar, and you can avoid the scar and put your incision beyond the scar area and assess for any thinned area and all with a preoperative ASOCT, and then plan your incisions there. And IOL calculation also sometimes it will be difficult in a scarred cornea. And, in that cases, either there are various methods like using the fellow eye K1, K2 values, or the topography, or the other methods like EKR readings and all. And patient counseling is also very important, and to give them the realistic expectations. Explain to them that we are dealing only with a cataract, but the corneal scar will remain. If there is peripheral scarring and all, there is no need of combining with a keratoplasty and all. Even phacoemulsification will give adequate vision to the patient. And biometry also, as I was telling, that can lead to unreliable values. You can use the other eye K readings or the topography, the mean values you can take and aim for a slightly myopic refraction to avoid postoperative hyperopia. Here also there is a minimal scarring. There are only peripheral opacities, but here also I am preferring subtenon anesthesia, and the phaco was performed in the usual manner. And if the view is hazy, you can use a tryptophan blue before your capsulorhexis. So the surgical intraoperative challenges can be a poor visualization of the capsule and the red reflex. If you don't have the retroillumination, very good retroillumination, the microscope also will vary in different OTs and all. Then you will have to deal with the irregular astigmatism postoperatively also. Sometimes the patients will have compromised endothelium, so you have to use agents like Viscot and all. And sometimes there will be danger for the capsulorhexis extension or the posterior capsule towards the equator and the posterior capsule rupture risk because there is poor visualization. And this is a case of Steven-Johnson syndrome. The other cornea was comparatively worse than this eye. So she was not having useful vision even with scleral lenses. So I took for cataract phaco for the better eye, the eye with a better cornea. But luckily the microscope had given me a good retro view, and even in spite of the very poor cornea vascularization and the opacities and all, phaco could be performed relatively better, and the patient is having good vision now. Only thing, they have to withdraw the contact lenses, scleral contact lenses for a week or so. The patient was finding it very difficult without the sclerals because of the lid margin keratinization, which recurred again in spite of a mucous membrane grafting of the eyelid. So these are the surgical challenges. And the visualization aids, as I was showing, tryphan blue staining of the capsule will be very useful. You can use either an endo illuminator or the oblique. You can tilt the microscope till you get the red glow. But if you are using the Lumira eye and all, there is no need for you will get a good red reflex. So this is a case of that peripheral scar where there was a small anterior seneca here, but the patient opted for a toric lens, and the surgery went on well because the central cornea was comparatively giving a good view. And if the cornea is getting drier and drier, you can use viscoelastic coating to get a smooth corneal surface and frequent irrigation to maintain the clear corneal zone. Avoid excessive light exposure to prevent the glare, because the scar itself will reflect so much light, and the glare will be more. So this is the toric marker, and finally the patient had got good result. So surgical modifications you can think as, if you feel like the rhexis will run out and all, you can aim for a small rhexis, either 4.5 or 5 for well control and low fluidics and phaco energy. Either you can do a divide and conquer or the direct chop method. And in this case, it was a poorly dilated pupil. So I have, this is a post-traumatic scar. This is a very subtle scar, but I have kept a 3-piece IOL because in traumatic cataract, you don't know the zonular support and the capsule support and all. And convert into manual SICS if the visualization is inadequate. So, but cases like this, look at this cornea, cases like this, you need a combined keratoplasty, triple procedure or a sequential keratoplasty, because of because there is no view, and there is no point in taking out the cataract alone, leaving this type of cornea. So the decision is based on the opacity size and the site and the surgical skill. To conclude, phacoemulsification in eyes with corneal opacities test not only your skill but our patience and judgment. With careful case selection, the right visualization aids, and gentle surgery technique, we can offer meaningful vision even through a cloudy cornea. So every clear postoperative cornea reminds us that clarity in surgery begins with clarity in planning. Thank you.
Thank you, ma'am, for that nice talk. And next speaker is Dr. Thomas Korikos. He will be speaking on surgical challenges in traumatic cataract management. Professor Dr. Thomas Korikos was previously in CMC Vellore, now a senior consultant and in charge in academics at Giridhara Institute, Kadavandra. Over to you, sir.
Thank you, Dr. Kalaimati, for this opportunity. So, what is special about traumatic cataract? There are many issues. Each one probably would warrant a lecture. Anyway, so you have young age, you can have children as young as 1 year who may have traumatic cataract. It's usually unilateral. You can have damage to other ocular structures. You can have damage to the lens itself or to the lens support. There may be associated ocular conditions like glaucoma, retinal detachments. Then there are issues with lens power calculation, issues with timing of the surgery, infections, and visual rehabilitation. Now, young patients, the big problem is inflammation. You can actually have inflammation and membrane formation on the table during surgery. And previously, it used to be a big problem. Now you have TPA, tissue plasminogen activator, which you can use during surgery. And you can also maybe give a small aliquot at the end of surgery, which will prevent this inflammatory membrane and synechiae formation. In children younger than 5 years, you have to be aware of amblyopia and make sure that is handled after surgery. The power of intraocular lenses, again, because the other eye is not likely to have cataract in the near future, you may need to either match it with the other eye or depending on what patients require, visual requirements is. Lack of accommodation in younger patients will mean that you'll have to give appropriate glasses for the same. All the structures from the cornea to the optic nerve can be damaged during trauma, and we really need to do a proper examination and assessment for in any case of traumatic cataract. We will primarily concentrate only in the first 4, which is what I think is more important for this audience. Cataract surgery with corneal opacity has already been well dealt with, Dr. Anita. The only thing I would like to add in this is she was talking about endo-illuminator. You can use what's called a chandelier. If the reflex is very bad, you can just stick in this thing and then continue your cataract surgery. Angle recession in traumatic cataract is only a problem if you're trying to use an anterior chamber lens. So it's probably best avoided in these patients. Again, don't forget to warn patients with angle recession of the possibility of developing glaucoma later on, because you can even be sued if you miss that out. Cyclodialysis is a problem only really when there is hypotony. You can do the cataract surgery and see sometimes a cyclodialysis and hypotony settles with that. If it doesn't, once the lens bag diaphragm is settled, stabilized after surgery, maybe after a month, you can repair the cyclodialysis. Small iridoid dialysis and iris tears can be left alone because, the contrast between the iris and pupil in our population is not great. So you really cannot make out too much. So you really need to repair iridoid dialysis only if vision is a problem. Repairing iris tear, the only suggestion is that don't make the pupil very small, because these patients can also have posterior segment problems, and so you need to titrate that. Round small pupil may not be the best in these patients. Coming to the lens damage, you can have capsular breach, both anterior or predominantly a posterior breach. You can have equatorial breach, especially if associated with intraocular foreign body. If you have primarily a bad posterior end and anterior capsule may be intact or may even have only a small rent, it may be a good idea to go pars plana, do a lensectomy, and clear up all the stuff from back of the eye and use the anterior capsule as a support for the intraocular lens. And this need not be done at the same sitting, and you can come back another date when the eye is quiet. Lens-induced uveitis usually starts only after 15 days of the injury because it's a sequestered protein. It needs time to develop uveitis. If there is severe inflammation before that, then one needs to be worried if there is whether there's an inflammation or not. Lens material is a good culture media, and lens abscess, if it's present, has to be intervened early and removed. In these patients, you may want to defer the lens implantation also. Zonular dialysis probably the most important for this audience. With zonular dialysis less than 180 degrees, you can manage with the current gadgets available. In these patients with zonular dialysis, you have to be careful of the vitreous that may come into the anterior chamber, and that needs to be dealt with. If there's a very bad zonular dialysis or the lens is dislocated, then one will have to go past plana and do a lensectomy. Here again, you need not be in a hurry to implant the lens. Once the eye is stabilized, you can go back for a second sitting. This video is just to show you the use of capsular tension capsular hooks and capsular tension ring. Here again, as I mentioned, ensure that the vitreous is not there. You can use steroids for that to check that out. Now the problem with capsular access is because the unstable lens, even making the first opening may be a problem. So it may be a good idea to poke with a sharp needle in the direction of the zonular dialysis rather than go posteriorly. The other thing is, when you use these hooks also help you stabilize the lens complex while you're doing a capsular access. When you're doing a capsular access, after making the first nick, try and tear it, do the tear perpendicular to the zonules to minimize stress on it. And here you notice that Dr. Sandhya has used these hooks to stabilize the bag as she goes along. So she does a little tear, then uses these hooks to stabilize that area. These ends of the hooks then go and stick to the equator and stabilizes the entire diaphragm well. If you are not happy with that also, then one can use these capsular tension ring, what you see here, and this can be done even before starting the phaco if you want. Otherwise, you may want to try the phaco at some point between. If you think things are unsteady, you can again use the ring at that point. Here you will notice that one can still see the edge of the bag, and even the CTR is still visible. One edge of the CTR is still visible, and then you may want to stabilize the bag a bit more. For that, you can use these ring segments, which are actually biplanar. The ring, this is in one plane, and this eyelet is more anterior. And here what one can do is, through the main wound, you can use the ring segment. You can use the main segment, main wound to put the segment. These segments, sutures or double arm sutures pass through the eye before you pass it into the eye. Once you have done that, the segment is then pushed into the bag. Be careful that the orientation is right as you go in. This edge of the ring will go into the equator, and then once you pull it outward, it stabilizes the bag. So this is what you're seeing here, and then this can be then through the ciliary sulcus. It can be taken out and sutured and stabilized. The whole thing is stabilized. So coming to the surgical dilemmas in traumatic cataract, immediate surgery only for patients who you suspect infection or the intraocular pressure is very high, or maybe a uveitis. Otherwise, it's better to quieten the eye and do the surgery. Anterior approach is preferred, and posterior approach is only if there's dislocation or if the posterior capsular rent is the primary problem. Primary intraocular lens, again, usually preferred, but if there is infection or severe inflammation, don't use a primary implant. Just one point in rehabilitation, when you have corneal wounds, please use contact lenses to manage the irregular astigmatism. An injured eye is like a broken wine glass. Restoration to the original is difficult. We should try our best regardless. Thank you.
Thank you, sir, for that excellent talk. Next talk is by the chief instructor. She'll be talking on phacoemulsification in vitrectomized eye, what a surgeon should know. Dr. Kalai is a senior consultant in cataract surgery, cataract services at Girdhara Institute. Over to you, Kalai.
Thank you, Dr. Sandhya. Good morning, everybody. My talk is on phacoemulsification in vitrectomized eye, what a surgeon should know. Why it matters? Because there is increasing number of posterior segment surgeries, there is a rise in post-vitrectomy cataracts, and cataract develops in 65 to 80% of the eyes within 1 to 2 years after PPV. And cataract surgery in vitrectomized eyes improves vision in more than 85% of the patients. And mechanism of cataract formation: once the vitreous gel is removed, oxygen from the retinal circulation diffuses into the posterior chamber and is in constant contact touch with the lens, oxidizing the lens, forming cataract. And the bright light from the fiber optic probe can also give rise to cataract. And direct capsular injury during the PPV can give rise to traumatic cataract. And tamponade like silicone oil and gas again can give rise to cataract. So preoperative evaluation is very important. History is very important. The indication for the PPV is important because the visual prognosis depends on the indication of the PPV. Slit lamp examination is important. We have to look for the pupillary dilatation, posterior synec, zonular weakness, phacodonesis, and pre-existing PCR, etc. And do a OCT to know the macular status, and a fundus examination in case of opaque media. And if the cataract develops within 4 months after PPV, you have to suspect a lens touch. IOL power calculation challenges. Axial length requires foveal fixation, and that is the main source of error in patients with macular pathology. And staphyloma or high myopia adds to this challenge. Optical biometry is preferred if fixation is adequate, and IOL Master 700 there is an integrated OCT system which can align well with the foveal fixation. So axial length measurement will be accurate in IOL Master 700. In case of opaque media, ultrasound biometry can be used. Biometry in silicone oil filled eyes. In case of mature cataract, we can use the optical biometer with silicone oil mode. But in case of dense cataract, we have to go for the ultrasound biometer. But in our center, we take the axial length of the other eye. Intraoperative concerns. Once the PPV is done, the vitreous cavity is filled with fluid. So there is no gel support during the cataract surgery. And the anterior chamber is deep and unstable, and the pupil is usually not dilated, and there will be synechial formation with weak zonules and excess lens mobility. So if you give a retrobulbar or subtenon's anesthesia, we can that increases the volume around the eye, thereby minimizing the sudden deepening when the probe is introduced. And capsular access is challenging because we have to put more pressure on the anterior lens capsule to initiate the capsular flap. And big rexus is recommended because sometimes you have to bring the nucleus out of the bag. Trypan blue is again recommended, and while injecting we have to be slow because it can diffuse into the posterior chamber. While initiating the rexus flap, if it is too hard, we have to suspect an occult zonular dialysis. Hydrodissection can be done in uncomplicated cases, and if you are suspecting a posterior lens touch, hydrodelineation should be done, and nuclear rotation should be gentle. The lens capsule complex moves with every fluid pulse. So sculpting in these cases will be very difficult. So nucleus removal should be done with chopping techniques as shown in this video, and a slow motion phaco should be carried out. There's something called reverse pupillary block which usually occurs in PPV cases. The laxity of the lens iris diaphragm, the pupil border gets stuck into the anterior capsule, and the fluid gets trapped in the anterior chamber, and the pupil gets dilated, and the maneuver becomes difficult. In such cases, the iris should be lifted. In the video you can see the iris should be lifted off the anterior capsule to reverse it. Pupil often constricts once it is reversed. So again you can see you have to lift the iris off the anterior capsule. If PCR happens, the lens should be brought out of the capsular bag, and lens scaffolding technique should be employed to lower the risk of dropped nucleus. Because the PCR happens, there is nothing like vitreous prolapse because there is no vitreous here. So we have to protect the nucleus from dropping down. So this lens scaffolding technique should be employed. Again, that is the placing the 3-piece lens in the sulcus with optic capture, and once the lens is placed, we can remove the nucleus after that. Capsular tension ring can be used if there is any sonular compromise. Cortical removal is again difficult in these cases because of the poor sonular stability, and because the capsular bag wobbles, and bimanual irrigation aspiration helps in such cases, and high chances of dialysis is there during IA. If the bag is intact, we can place a single piece IOL in the bag, and if there is PCR, we have to place the 3-piece IOL in the sulcus with optic capture. This video is to show how optic capture is being done. The IOL is placed in the sulcus, slightly rotated, and my zonular dialysis is there in this area, but the IOL is stable, and now the capture is being done. Just push it behind the anterior capsule. That's it. Complication management: if there is nucleus drop, retrieve the nucleus via plas plana, and if there is no capsular support, scleral fixated IOL can be used, or iris claw lens can be used. Postoperative complications include cystoid macular edema, recurrent retinal detachment, posterior capsular opacification, and late IOL dislocation. So to summarize, cataract surgery after PPV improves vision in majority. Understand the altered chamber dynamics and fluidics. Accurate biometry is critical, and modify the surgical technique to minimize complications, and monitor for CME, RD, PCO, IOL displacement. Thank you. Our next speaker is Dr. Sandhya. She is senior consultant and center head and Giridhara Institute, Edappalli. Over to you, Dr. Sandhya. She'll be talking on cataract surgery in nanophthalmus and colobomatous eye.
Thank you, Dr. Kalle. So, cataract surgery in nanophthalmos and colobomatous eye. This patient had a refractive error of plus 8.5 diopter in the right eye and plus 10.5 diopter in the left eye. She had small eyes, shallow anterior chamber, and a near total cataract. The axial length was 19.69 and aqueous depth was 2.18. That is, the eye was in the nanophthalmic range. And the IOL power calculation is going to be a challenge in these eyes because even small changes in the effective lens position can cause significant post-op refractive error because of the high power of the intraocular lens. And these eyes are more prone for suprachoroidal effusion, hemorrhage, and malignant glaucoma. So in this case, we have to do a preoperative UBM to rule out any pre-existing uveal effusion. And the patient should be informed preoperatively regarding the chance of postoperative refractive surprise and the complications like expulsive hemorrhage and suprachoroidal effusion. So 360-degree limbal peritomy was done and 2 partial thickness scleral windows were made to take care of uveal effusion that may arise during intraoperatively in these small eyes with thick sclera. So after that, the paracentesis should be beveled to reduce the incidence of iris prolapse because these eyes are small and there is only less space. The pupil was not dilating well even with intracameral adrenaline, and since the red reflex was poor, trypan blue was used to stain the capsule. And to improve visualization, iris hooks were used. Iris hooks are preferred to other pupil expansion devices in shallow anterior chamber. You can also use a BHEX ring which has a vertical clearance of only 0.75 millimeter. And these hooks should be tightened carefully not to avoid damage to the iris margin. And then you should not make a baby size rhexis in these eyes because then it will be difficult to get the nuclear pieces out of the capsular bag. And again, the clear cornea incision should be slightly longer to reduce the chance of iris prolapse. And hydrodissection should be gentle. You should inject small amount of fluid at multiple places so that the sudden gush of fluid doesn't lift up the lens and cause iris prolapse. So the small eyes have got a very high incidence of iris prolapse, so you should be careful. So after ensuring nucleus rotation, this nucleus was emulsified using low phacoparameters. This low fluidics is important to avoid sudden chamber fluctuations. We can precipitate uveal effusion in these nanophthalmic eyes. And you should divide the nucleus into smaller pieces and then you should emulsify it at a deeper plane after protecting endothelium with dispersive OVD. Because the anterior chamber is, you should avoid the tendency of prolapsing the entire nucleus into the anterior chamber and then emulsifying it because there is high risk of endothelial damage in these small eyes with very shallow anterior chamber. Now after nucleus emulsification, before withdrawing the irrigation cannula, before withdrawing any instrument with infusion, you should inject OVD to prevent sudden shallowing of chamber which again can precipitate a uveal effusion in these predisposed eyes. So at the end, a 36 diopter foldable acrylic lens was implanted in the eye and the 2 haptics were carefully placed. And in the bag, implantation of IOL is very important in these small eyes. And before OVD removal, the iris hooks were carefully taken, the silicone sleeve was retracted and the hooks were taken parallel to the paracentesis. Now pilocarpine was injected to constrict the pupil and OVD was removed carefully. During this time there was iris prolapse that was reposited through the clear corneal incision. So in this case there was iris prolapse multiple times, so there was already a hole in the iris, so a separate iridotomy was not done. Otherwise you will have to do an iridotomy at the end to prevent malignant glaucoma. So the learning points are, the accurate IOL power calculation is difficult in these small eyes because the IOL power is very high and even small changes in the ELP can cause significant post-op residual refraction. Patient should be informed about this preoperatively. And preoperative IOP measurement, gonioscopy, UBM, B-scan are important. And if the anterior chamber is shallow, a peripheral iridotomy should be done. Proper patient counseling regarding intraoperative complications is important. You should take precautionary measures to counteract the uveal effusion. Beveled incision and longer corneal tunnels are important, and never overinflate the anterior chamber. The careful and gentle hydrodissection is very crucial, and avoid anterior chamber phacoemulsification, and avoid frequent chamber fluctuation and shallowing to reduce the incidence of uveal effusion. And IOL should be ideally placed in the bag and a peripheral iridotomy should be done. Now this patient had iris coloboma and retinocoroidal coloboma, and she also had a very small eye and the axial length was less than 21, In addition to this, she also had a small peripheral synecdoche in the infratemporal quadrant. So beveled incisions were made, and trypan blue should be only little trypan blue you should inject so that it doesn't go through the colpomatous area and stain the vitreous. And after this, as you can see, when the rhexis was initiated, the entire bag lens complex was moving. So sonule weakness is very common in eyes with coloboma. So we should be mindful about this and should take adequate precautions. So after clear cornea incision, a gentle hydrodissection was done, and take care not to inject so much of fluid, but even with careful hydrodissection, there was iris prolapse through the clear cornea incision, so it was reposited. Whenever you are introducing phaco probe through an incision where there was already iris prolapse, you should switch off the irrigation and then introduce the phaco probe. And once you reach the eye, you have to switch the irrigation on. Now again, the phacoemulsification was done with low motion phaco was done, and during aspiration of the last piece, so OVD was injected to prevent sudden chamber collapse. During aspiration of the epinucleus, you can see the entire bag was moving, so I had to keep a Sinskey hook beneath the phaco probe to prevent aspiration of the entire bag. So it was done very slowly, and then as you can see here, the cortex was very sticky, it was not coming at all. This is because of the lack of counter-traction by the healthy sonules. And once the OVD was injected, the anterior rhexis margin started moving centrally. This again is an indication of severe sonule weakness. Triamcinolone was injected, and there was no vitreous in the anterior chamber. So a CTR was placed to give equatorial support to the capsular bag, and this will strengthen the sonules all around. And after this, a 29 diopter lens was implanted, a single piece foldable lens was implanted inside the bag. As you can see here, this lens was almost filling the entire eye. And then this was carefully dialed into the capsular bag. Now in this patient with coloboma, she had a mature intumescent cataract and the anterior chamber was very shallow. So here rhexis is going to be difficult because of two reasons, because there is lack of red reflex is there and there is high intra-bag pressure with a convex anterior capsule. So you should nicely fill the anterior chamber with OVD so that the anterior capsule is flattened. And first I made a small primary rhexis, and then once always try to pull it centrally so that the rhexis doesn't extend to the periphery. And once the cortex was aspirated, there was this black cataract beneath. And so to improve visualization, here also iris hooks were used, and a tangential cut was made on the rhexis, and this was enlarged secondarily. Throughout this rhexis maneuvers, you should always fill the anterior chamber nicely so that it is pressurized and the rhexis doesn't extend to the periphery. Now while trenching and dividing the nucleus, see the nucleus slightly got tilted, and then because there was less space, it produced a large posterior capsule dehiscence. So I decided to convert it into SICS, and a new scleral tunnel was made, and this was taken out, and could see a large split in the posterior capsule. So anterior vitrectomy was done to clear the vitreous from the anterior chamber, and after
Thank you, Dr. Sandhya.